interdisciplinary referrals to the ophthalmologist. Usually, if we are working in a multidisciplinary hospital or medical colleges, we used to get references from other specialties like obstetrics, neurology, and other specialty. So we try to cover majority of our references we are getting. The first speaker is Dr. Dahlia. She will be speaking on ophthalmology cross consultation in pregnancy. She is professor in Alleppey Medical College. Over to you, Dahlia.
Good morning, all of you. Pregnancy can produce changes on all the systems in a female, including the eye. And the eye changes in pregnancy can be both physiological or pathological. This is mainly because of the hormonal imbalances occurring during pregnancy, and early recognition and management is important to prevent sight-threatening complication. Obstetric complications per se can also have ophthalmic signs, and prompt recognition is important, and it is life-saving to both mother and the fetus. And the safety of common ophthalmic medications are also important. The ophthalmic changes in pregnancy can be grouped as coming in the anterior segment, posterior segment, neurophthalmic changes in pregnancy, and these are some of the certain systemic conditions which can complicate pregnancy with eye manifestations. So we'll see some of the important ones. Increased pigmentation around the eyes is, or otherwise called as melasma, is the most frequent physiological change, and for this no active intervention is required, and it fades slowly over several months after pregnancy. Coming to the cornea, the thickness of the cornea increases due to water retention in the late trimester, and the curvature of cornea can increase by 1 diopters, again because of the hormonal changes occurring. And these refractive changes resolve after pregnancy, 3 to 6 months after pregnancy. Therefore, what is important is a new spectacle, contact lens, or prescription to be given, or laser refractive surgeries should be avoided during pregnancy. And in keratoconus patients who show progression, always consider C3R prior to conception to prevent progression of ectasia during pregnancy. Corneal sensitivity decreases towards the end of pregnancy because of the increase in corneal thickness, and there is increased risk of infection, and contact lens wear is risky, and return to normal 2 months postpartum. Dry eye increases with increase in the gestational age. It is mainly evaporative, and the mechanism is the hormonal changes affecting the ocular surface, and also prolactin damaging the lacrimal acina cells. It is treated with lubricant eye drops with no adverse neonatal outcome. Lens curvature increases because of the excessive hydration and produce myopic shift, and there can also be temporary loss of accommodation. Cataract per se is rare, and if it occurs, it's congenital and genetic, and surgery is best deferred until postpartum because of the risk of anesthetic agent. Glaucoma in pregnancy, there is a physiological decrease in IOP by 2 to 3 millimeters of mercury because of the increased uveoscleral outflow and increased aqueous outflow by the hormone acting. Increased level of female sex hormones is actually neuroprotective to the optic nerve. Therefore, existing glaucoma improves during pregnancy, and the need for anti-glaucoma medication can be reduced. The IOP returned to baseline 3 months postpartum, and therefore a close follow-up is required. Most of the anti-glaucoma medications are Class C drugs by FDA. Brimondin is well tolerated throughout, but has to be stopped before delivery because of the risk of fetal apnea. Topical beta blockers is safe. Carbonic anhydrase inhibitors is the optimal choice in the 3rd trimester because of the risk of brimondin. PG analogs has to be avoided because it crosses placental barrier and stimulate uterine contractions, causing spontaneous abortions. Those cases which are refractory to glaucoma can be taken up for surgery, but the concerns are anesthetic agents, supine positioning, post-op medications, and use of antimetabolites. Uveitis, there is a suppression of the immunity because of, and there is an increase in the cytokine levels. Then alpha fetoprotein secreted by yolk sac is actually protective to the fetus. So uveitis decreases after the 1st trimester, but postpartum it flares up. Mild cases can be treated with steroids, which is safer. Moderate to severe cases can be treated with oral steroids or other immunosuppressive agents, and these are the drugs which have to be avoided. always counsel patients of the childbearing age having uveitis regarding the risk in pregnancy before they are started on immunosuppression treatment. Diabetic retinopathy is less common in gestational diabetes. Therefore, no regular retinopathy screening is advised in gestational diabetes. But if the patient is already diabetic becoming pregnant, type 1 and type 2 can have a progression of the retinopathy. Diabetic macular edema will worsen in patients with proteinuria hypertension, and these are the risk factors as in other cases. Because of the follow-up schedule which has to be taken up is diabetic females who are considering pregnancy, a preconception ocular examination, and then in the first trimester is advised. If any retinopathy is present, it is reassessed 16 to 20 weeks. But if there is a severe retinopathy present with coexisting other comorbid conditions, a close follow-up is required. Gestational diabetes, no screening is advised during pregnancy. Treatment, laser is better done pre-pregnancy. Anti-VEGFs are better avoided. If diabetic macular edema is present, you can give intravitreal steroids, and these are the indications for surgery. CSR, because of the increased level of cortisol and other hormones, is common in the third trimester, which resolves spontaneously after delivery. FFA is contraindicated, and diagnosis and follow-up is by OCT. IAS, there is an increased risk because of the hormonal change and weight gain during the antenatal period. Symptoms are as in other cases, and oral acetazolamide is class 2, which can produce teratogenic effects, so better avoided in pregnancy, especially in the first trimester. Severe symptoms and gross ONH swelling, you can have lumbar puncture or lumbar drain. If very much required, Diamox can be started in the second trimester after consultation with the obstetrician. Cranial neuropathy, 7th nerve is common, also the 6th and 4th nerve, which is common in the late pregnancy. Complete paralysis and incomplete resolution is a rule, and therefore early treatment with steroids is recommended. Spontaneous orbital hemorrhage can occur during the first trimester, during labor, and patients on anticoagulant therapy resolve spontaneously, and therefore no treatment is required. These are the systemic conditions which can complicate pregnancy with eye manifestation. 25% of preeclampsia and 50% of eclampsia patients can have visual symptoms as similar in other cases. And the most important finding in the fundus is retinal arteriolar narrowing, especially nasal to the disc, also hemorrhages and optic nerve head edema. And the severity of retinopathy is inversely related to the fetal birth weight. Acute vision loss in these patients can be because of cortical blindness of serous retinal detachment. In cortical blindness, you will get a normal fundus and pupil reaction, and the vision loss is 4 to 7 hours prior to seizure. Accelerated hypertension can produce serous retinal detachment, and the patients will regain full vision postpartum with resolution of it. 10% of preeclampsia and eclampsia patient can develop the HELP syndrome. When you're asked to see the fundus, if you see an arteriolar narrowing, you have to advise to immediate termination of pregnancy. Graves, gestational hyperthyroidism and orbitopathy can occur in 0.2% of pregnancy. Most common is Graves. The diagnosis is difficult because it alters the lab test. Treatment is by antithyroid drugs, and the teratogenicity has to be considered. Any pregnant female with complaints of headache, decreased vision, diplopia, or bitemporal hemianopia has to be investigated for pituitary adenoma, which may enlarge during pregnancy. And most of these adenomas and visual symptoms will regress postpartum. So to conclude, physiological and pathological ophthalmic manifestations are common in pregnancy. Ophthalmic manifestations can occur with obstetric complications also. Early recognition and treatment can prevent sight-threatening complications, and a multidisciplinary approach is needed to treat certain conditions. Pre-existing eye conditions has to be monitored closely during pregnancy. In cases required, preconception counseling should also be advised, and the teratogenicity of drugs are to be considered in taking decisions on treatment. Thank you.
Thank you, Dr. Dahlia. Usually, majority of the signs and symptoms will reverse after delivery, following 2 to 3 months of delivery. But some changes, just like in exudative detachment of eclampsia, patient may have a residual visual loss in pregnancy. And in some situations, we get consultations because of a gestational diabetes. So Dr. Dahlia has explained that gestational diabetes per se won't produce any retinopathy, but if the patient is, if the person is before pregnancy, she was diabetic, and there is a chance of retinopathy, then close monitoring of retinopathy status is very important. not the gestational diabetes, but a diabetic patient who is become pregnant. Majority, the symptoms and the signs will resolve after pregnancy. Now we will move on to the next talk. Dr. Mini PA will be talking on ophthalmology consultation from neurologist. It is a very elaborative specialty because, as we know, the eye is a window to the brain. We get so many consultations from neurologists. Over to you, Mini.
Good morning. So my topic today is ophthalmology consultations from neurologist. A patient presenting with defective vision, headache, diplopia may be referred to ophthalmologist for detailed evaluation by the neurologist and also for visual field evaluation and disc evaluation. A patient presenting with defective vision may have transient visual loss which lasts for less than 24 hours or persistent visual loss. Transient visual loss can be lasting for few seconds as in papilledema or lasting for few minutes as in retinal and optic nerve ischemia. So always note the onset, progression and duration of defective vision. For example, in central retinal artery occlusion, there is sudden onset defective vision without subsequent progression, whereas in ischemic optic neuropathy, sudden onset with subsequent progression over days. And in inflammatory optic neuropathy, there is subacute onset which progresses over few days to few weeks. And in compressive or toxic or nutritional optic neuropathy, there is insidious onset and gradually progresses over months. And it is important to note the laterality of vision loss and associated clinical features to identify the cause of defective vision. Example, in optic neuritis, there will be painful eye movements, or in demyelinating causes, associated neurological features may be there. And in causes due to orbital or cavernous sinus lesions, there can be associated proptosis or diplopia, or in causes due to giant cell arteritis, patient can have headache, jaw claudication, scalp tenderness, etc. And in defective vision due to retinal and macular causes, patient may complain of metamorphopsia, floaters and photopsia. So coming to clinical examination, it is important to assess visual acuity, color vision, contrast sensitivity, then anterior segment evaluation, in which examination of pupil is very important to rule out relative afferent pupillary defect. Then posterior segment evaluation and visual field evaluation. And depending upon the cognitive status of the patient, we have to decide which are the tests which can be done for each patient. And confrontation visual field testing is a simple and quick test to detect homonymous hemianopia, which is seen associated with cerebrovascular accident. So such patients having CVA will present with, even though they have bilateral homonymous hemianopia, patient may complain of monocular visual loss in the eye with the temporal field defect. And an automated perimetry is important in diagnosis of various optic neuropathies like AION, optic neuritis, and in papilledema, and in localization of the lesion in cerebral causes of defective vision. Then in optic neuropathy, common field defects seen are central and centrocecal scotoma, arcuate scotoma, altitudinal defect, and temporal wedge defects. And in chiasmal and retrochiasmal lesions, the patient will have hemianopias affecting both eyes. In central chiasmal lesion, usually patient will present with bitemporal hemianopia, whereas in retrochiasmal lesion, it is contralateral homonymous hemianopia. As you go more posteriorly, the lesion will produce more identical or congruous types of homonymous field defects. So in lesions in lateral geniculate body can produce a congruous horizontal sectranopia. And lesion in temporal lobe, which affect inferior visual fibers, will produce a homonymous superior quadrant anopia known as pie in the sky defect. And a parietal lobe lesion, which affects superior visual fibers, will produce pie in the floor type of field defect. And in occipital lobe lesion, or usually we get a congruous type of homonymous hemianopia, usually sparing fixation. But in systemic hypoperfusion, where perfusion in both middle cerebral artery and posterior cerebral artery is affected, patient can present with homonymous hemianopic central scotomata. And in bilateral occipital damage, patient can have cortical blindness. A normal pupillary response and a normal optic nerve head appearance will help us in differentiating cerebral blindness from blindness caused by lesions in the anterior visual pathway. The next condition where we get consultation from a neurologist is for evaluation of optic disc to rule out disc edema or optic atrophy. While examining the disc to rule out disc edema, note the blurring of disc margin, hyperemia, filling of cup, presence or absence of spontaneous venous pulsation, and disappearance of already recorded SVP is more significant in diagnosis of papilledema. If there is any doubt, FFA or OCT will help in confirmation of disc edema. And in ruling out optic atrophy, look at the color of the disc, cup, optic disc margins, surrounding retina, and retinal vessels, and differentiate primary from secondary optic atrophy. Always rule out consecutive and glaucomatous optic atrophy. Usually in chiasmal lesions, in both eyes, the optic disc will show horizontal botoid atrophy. And in optic tract lesions, the contralateral optic disc may show horizontal botoid atrophy and the ipsilateral disc will show vertical botoid atrophy. Some of the investigations which can be done for these patients include fluorescein angiography, which will help in differentiating true disc edema from pseudo disc edema and also in diagnosis of giant cell arteritis. And fundus autofluorescence will help us in diagnosis of optic disc drusen, which is a cause of pseudo disc edema, and it will also help in ruling out certain maculopathies. And optical coherence tomography will help in various optic neuropathies, as it will give indirect evidence regarding the neuronal loss in optic neuropathy. It is important in compressive chiasmal lesions, as OCT can predict the potential for visual recovery after surgical decompression. Because a patient having significant visual field defect but preserved peripapillary RNFL thickness have excellent prognosis for visual recovery after surgical decompression. Then ERG may help us in differentiating causes due to macular disease and optic nerve disease. Another condition where we get reference from neurologist is a patient presenting with diplopia. Common causes are 3rd, 4th and 6th cranial nerve palsies. And these patients present with diplopia with typical strabismus pattern. We have to do a detailed ocular motility examination and do a diplopia charting. And we can identify the muscles affected and thus the cranial nerves which are affected. When diplopia does not follow a specific cranial nerve pattern, other causes like myasthenia, thyroid eye disease and caroticocavernous fistula should be considered. And always differentiate paretic from restrictive causes of diplopia by forced duction test. And Maddox-Rod test will give us information about the degree and pattern of ocular misalignment. And associated clinical features also help us in anatomical localization. For example, in cranial nerve nuclear and fascicular lesions, there will be associated neurological deficits in addition to ophthalmoparesis. And lesions of cavernous sinus and orbit, patient can present with multiple cranial nerve palsies. And in internuclear lesions which affect the medial longitudinal fasciculus also, patient can present with diplopia. And it is important to note that a non-traumatic pupil involving third nerve palsy always rule out aneurysm at the junction of posterior communicating artery and internal carotid artery. And look for any aberrant regeneration of third nerve. Usually it occurs after traumatic or compressive lesions, not after microvascular ischemia. Then a patient with facial nerve palsy may be referred to ophthalmologist. Always look for the amount of lag ophthalmos, any evidence of whether there is good Bell's phenomenon or not, and any evidence of exposure keratitis. And a patient with headache will be referred to ophthalmologist, and always rule out refractive error, any latent strabismus, any elevated intraocular pressure, or any evidence of ocular inflammation. And don't forget to do a fundus examination to rule out papilledema. Sometimes a patient having hereditary and systemic conditions may be referred to ophthalmologist to look for ocular manifestations of the systemic disease. For example, in phakomatosis like neurofibromatosis, to look for leash nodules. Then to conclude, common indications for referral from neurologist to ophthalmologist include defective vision, where we have to note the onset, duration, progression, laterality and associated features, and diplopia. An ocular motility examination will reveal the cranial nerves which are affected. And in headache, rule out refractive error, strabismus, glaucoma and ocular inflammation. And visual field testing will help us in localization of the lesion. And disc evaluation can be done to rule out optic disc edema and optic atrophy. Thank you.
Thank you, Dr. Mini. So neurology is a very vast topic. Mini has talked in a nutshell. Recently, we had a patient who presented with a partial painful third nerve palsy, and we thought of a patient had a posterior communicating artery aneurysm, and we admitted the patient and MRI was done, but it turned to be a glioblastoma multiforme which infiltrating into the brain third nerve, and it is encasing the third nerve. So rare presentations can also occur. So initially we were thinking of this posterior communicating artery, which is the common presentation, as painful third nerve palsy. So sometimes you may get this type of rare presentations also. The next talk is by Dr. Sija. She is Associate Professor in Government Medical College, Alappuzha. She will be talking on thyroid orbitopathy, which is also again a very common reference we are getting from endocrinologists. Over to Dr. Sija.
Thank you, madam. So regarding cross consultations from endocrinology department, the maximum number of cases we get is diabetes. Then comes the thyroid disease. So what to look for in a patient with thyroid disease? The eye symptoms and signs that occur associated with thyroid dysfunction are called thyroid eye disease. They are under various names: Graves' orbitopathy, ophthalmopathy, thyroid associated ophthalmopathy. And in the severe form, it is sight-threatening, debilitating and disfiguring, and it has a huge impact on the quality of life. It is 90% associated with hyperthyroidism, which we don't usually miss. But the 6%, which are usually associated with euthyroid, that is a subset we are likely to miss. Less common with Hashimoto's thyroiditis and primary hypothyroidism. Whenever patient with thyroid symptoms, eye disease, if they have an associated ptosis or exotropia, myasthenia should be ruled out. Regarding epidemiology, in Graves' disease, the prevalence is very high, in the range of 25 to 58%. Some of these patients present to us directly with mild symptoms, maybe mild irritation, foreign body sensation, watering. So whenever we have some suspicion, we have to order for the thyroid function test. And those patients, eventually they develop thyroid dysfunction, about 25% in 1 year and 50% in 5 years. Regarding Indian population, they have less proptosis but more of lower lid retraction. And Asian populations, they have more of this thyroid optic neuropathy. Incidence is more in females, but going to the severe form, males are more involved. Regarding pathogenesis, it is an autoimmune induced development of antibodies. So there will be infiltration of immune cells into the orbital tissues, which activates the T cells and B cells. And these produce antibodies against the TSH receptor and IGF-1 receptor, which are present in the orbital fibroblast. And these antibodies, they stimulate these receptors. They get attached and they stimulate these receptors. And what happens? They can increase cytokines and chemokine production. The orbital fibroblast undergoes adipogenesis, transformation to myofibroblast, and increased secretion of glycosaminoglycans and hyaluronic acid. So in short, the orbital volume increases, and that is responsible for all the clinical signs. Clinical features, there are many signs on order. Most common is the eyelid retraction followed by exophthalmos, lid lag, ocular pain, lacrimation, diplopia. Though less common, the sight-threatening one is optic nerve disease and severe exposure keratopathy. Named signs, there are many which is not beyond it is beyond the scope of this presentation, so I'll just mention one or two. Dalrymple sign, which is upper lid retraction, especially with the lateral flare. Then Goldsiger sign, which is deep injection of the bulbar conjunctiva, and we can specifically see injection at the level of the insertion of recti muscles. Vongraphy sign, low upper lid lag on looking downwards. Stelvag sign with a staring look. Why you get a dysthyroid optic neuropathy? It is a compartment syndrome. We said the orbital volume has increased, muscle has increased, fat has increased glycosaminoglycans. So all these exert pressure on the optic nerve at the orbital apex. And the features of optic neuropathy are diminished visual acuity, RAPD, optic disc edema, abnormal color vision, abnormal fields. Contrast is also reduced. When to make a diagnosis of thyroid eye disease? If 2 of the 3 signs are positive, if there is a concurrent or a recently treated immune-related thyroid dysfunction, or if the patient has a typical ocular signs like chemosis, caruncular edema, strabismus, or a radiological evidence. If 2 of the 3 are present, we make a diagnosis of thyroid eye disease. What are the risk factors? Smoking, that is the most important risk factor. So irrespective of whether the patient has a thyroid eye disease or not, whenever a patient with some thyroid disease comes to us, we have to ask them to quit smoking because they have an increased prevalence of thyroid eye disease and also increased chance of recurrence because of the oxidative stress and also hypoxia. Another important is we have to maintain a euthyroid status always. Though the severity doesn't match the level of T3, T4, we have to maintain a euthyroid status. Radioactive iodine treatment has also increased chance of development of thyroid eye disease. So we give systemic steroids along with that. Lower selenium concentration, vitamin E deficiency, obstructive sleep apnea, all are risk factors. Male gender, old age, and diabetes, they have chance of increased severity of the disease. Natural history, it is a biphasic, it's known as a Rendel's curve. Initially, there will be an active phase, whether there is a progression for about 6 months to 2 years, can even extend up to 3 years, where all signs of inflammations are there. There can be erythema, chemosis, inflammation with proptosis, lid retraction, and strabismus. Now coming to the static stage, which is about 2 years or 3 years later, here the proptosis will be there, lid retraction, strabismus will be there, but with no signs of inflammation. So first picture you can see that it's an active, whether there is proptosis there but with inflammation. Second, it is quiet eye. So what are the investigations? Like any other proptosis, all the basic investigations we have to do, like visual acuity, color vision, visual field, pupil, ocular movements, Hertel's exophthalmometry for serial follow-ups, intraocular pressure, slit lamp, and dilated fundus examination. Evaluation, we have to do a thyroid function test at the initial presentation itself. Orbital imaging can be done, CT or MRI. Here you can look for muscle belly enlargement with tendon sparing, and especially look for the orbital apex to look for compression. Antithyroid antibodies should be sent, especially TSH receptor antibody and thyroid peroxidase antibodies. Clinical scoring system. There are various scoring systems we have studied, like NOSPECS, VISA, and the 2 variables mainly studied are the activity and severity. I'm not going to the details. VISA scoring mainly is vision, inflammation, strabismus, and appearance. And clinical activity score, here we have scoring at the initial visit and also at subsequent visits. At the initial visits, 7 parameters are studied, and if more than 3 is involved, we say it is active. And in subsequent, after 1 to 3 months, we reassess the patient, and if there is increase in proptosis, decrease in movements, and decrease in one line visual acuity, we make the score out of 10. And if it is more than 4, it is active. UGOGO classification, that is European Group on Graves of Orbitopathy, that is more important nowadays because it helps in the management. It's a mild UGOGO, that is, which has a minimal impact on the patient's life, where immunosuppression is not warranted. That is minor lid retraction, mild soft tissue involvement, exophthalmos less than 3 mm, transient or no diplopia, and corneal exposure responsive to lubricant. So what do we offer to such patients? We have to ask them to stop smoking, reduce the salt intake, ask them to have a head and elevation. For eye symptoms, we can give artificial tears, topical cyclosporin, sunglasses to prevent photophobia. Diplopia, we can give prisms or Botox injection. Selenium supplementations can be done. Moderate to severe cases, which has sufficient impact on the quality of life, so it warrants immunosuppression on, if needed, surgical intervention also. Here, all the symptoms, signs we have mentioned as increased, that is lid retraction, soft tissue involvement, exophthalmos, it's more than the milder form. Here, first-line treatment is IV methylprednisolone with mycophenolate mofetil for 6 weeks. That is 0.5 gram per week is given. And if the patient is responding, we can taper the dose for another 6 weeks. But the cumulative dose should be kept at 4.5 gram. If the disease is not responding and it is still active, we can try a increased dose of steroids. Second-line treatment is with cyclosporin or azathioprine, and orbital radiotherapy is also considered. Newer drug, that is the targeted therapy, we said the receptors and the pathogenesis. So teprotumumab, which is against IGF-1 receptor blocker, that is in the line. The other ones are tocilizumab, rituximab, etanercept, which is against in all the chemokines. Sight-threatening cases, we have to give high-dose IV methylprednisolone and, if needed, surgical decompression. Inactive stages, there is no role for any anti-inflammatory, but we need surgical management. So sequentially, orbital decompression is done depending on fat predominance or the bone predominance. We can fat removal or bone removal. Then we can go for extraocular muscle surgeries and, if needed, eyelid correction. Thank you.
Thank you, Dr. Sija. So always look for the vision-threatening complications in thyroid orbitopathy like optic neuropathy and exposure keratitis. And if in early cases you see the color desaturation, pupil, look for RAPD. And if the patient has got any signs of optic neuropathy, start the patient on IVMP, either pulse dose or you have to give 3 doses for 1 gram and continue, maximum up to 8 milligram. Now the next talk is by Dr. Anna Elias on ethambutol toxicity, all you need to know. Dr. Anna is senior consultant in Giridhara Hospital and she has immense experience in seeing patients with an ethambutol toxicity, and she will be elaborating on the topic. Over to you, Dr. Anna.
Yeah. Thank you. Good morning. I will be talking about ethambutol toxicity, all that you need to know. Ethambutol is an antibiotic with antimicrobial and antitubercular properties. It is bacteriostatic against actively growing TB bacilli, and it works by obstructing the formation of the Mycobacterium cell wall. It was first introduced in 1961, but exactly a year later, Carr and Henkind first reported ethambutol-induced optic neuropathy. So unfortunately, one serious and vision-threatening side effect of ethambutol is toxic optic neuropathy. And the prevalence of ocular toxicity ranges from 1 to 2.5% with the recommended dosage of 15 milligram per kg. The toxicity is dose-dependent, as you can see from the table. What is the exact mechanism? See, the neurotoxic effect of ethambutol, exact mechanism is not known, but it is believed that the metal chelating effect of this drug may be responsible. It chelates copper and zinc. So as a metal chelator, ethambutol can disrupt oxidative phosphorylation and it can affect the mitochondrial function. So defective mitochondrial function compromises the effective axonal transport. See, RGCs are susceptible to ethambutol damage because of the high cellular content of mitochondria. So this is a ganglion cell and this is the nucleus. You can see that this is the mitochondria. So ethambutol actually causes the accumulation of reactive oxygen species, and this causes spores to develop in the mitochondria, and from these spores cytochrome C is released. This combines with apoptosis activating factor, and this results in a cascade of reactions which results in apoptosis. And the final result is death of the ganglion cells in the retina, resulting in visual field loss. So the investigations for ethambutol toxicity are a comprehensive ophthalmic evaluation, including a best-corrected visual acuity, color vision, Amsler grid testing, pupillary reaction, slit lamp, IOP, a dilated fundus examination, visual field examination, visual evoked potential, which is very important, SDOCT, and color photo of the fundus. So unlike other toxic optic neuropathies, ethambutol toxicity can occur at a very short period. It generally occurs in doses higher than 15 milligram per kg, and symptoms usually start in 3 to 5 months. And majority of the patients present with bilateral, painless, symmetrical loss of central visual acuity and dyschromatopsia. So the visual acuity loss, it can be minimal or it can be severe. And the color vision loss, it could be one of the first signs, and it typically presents with loss of red-green color perception. Now, central vision loss is the most important visual field defect. However, other possible visual defects include bitemporal hemianopia. So this is the HFA 30-2, so showing the central scotoma, and this showing the bitemporal hemianopia. So initially, pupillary responsible may be normal, but later it can be sluggish. But relative afferent pupillary defect is difficult to elicit because changes are usually bilateral and symmetric. The optic disc in the initial stages appear normal, but as toxicity progresses, optic disc pallor will set in. So visual evoked potential, this is actually one of the most important diagnostic criteria, early sensitive diagnosis of ethambutol toxicity. So basically, ethambutol, it slows down the conduction, neural conduction to the occipital cortex. So in a VEP, you'll find that there's an increase in the latency of the P100 wave. P100 is the, at 100 milliseconds, the first positive wave. So when there's an increased latency and also a reduction in the amplitude. So VEP is actually considered an early biomarker. And studies have shown that VEP can be useful for detecting subclinical optic nerve damage in patients taking ethambutol. That is, even before the vision actually reduces, if you do a VEP, you may get some early results. So this is the SDOCT showing the ganglion cell complex. As you can see, there is severe thinning of the ganglion cell layer in both eyes, and temporal GCIPL. That is actually a reflection of the severity of ethambutol toxicity. As far as RNFL thickness, in the initial stages, it may be normal or even high, but in the later stages, it shows thinning. So there are certain risk factors. Not everybody on ethambutol goes into toxicity. So the risk factors are old age, higher dosage, longer duration. See, longer duration, like patients who are on spinal TB, they may need at least 1.5 to 2 years of ATT. Renal disease is a very important risk factor. Then low weight, then systemic diseases such as diabetes, hypertension, malnutrition, and of course alcohol, tobacco abuse. Also the concurrent use of isoniazid, and also in preverbal children. So there is no effective treatment for ethambutol-induced optic neuropathy other than stoppage of the drug. But early detection of the disease and stopping ethambutol may prevent further deterioration. So the damage is reversible if discontinuation of ethambutol is done at an early stage. Around 30 to 50% patients show recovery to a variable extent after 6 to 9 months of stopping ethambutol, which means that almost 50%, a large percentage, will go on to irreversible visual field loss. That is why this is important. And visual functions may continue to deteriorate even after stopping the drug. So that can be very distressing for the patient and for the doctor. So supportive treatment in the form of vitamins, but the dose is important. Methylcobalamin, 1500 microgram, pyridoxine, thiamine, and also zinc and copper are helpful. So a little bit about epidemiology. There are 10 million cases of tuberculosis worldwide, of which a large percentage, that is 27%, are prevalent in India. And 55% patients will be on ethambutol. If you take a risk of 1 to 3%, that accounts for about 22 to 66,000 cases per year. So initially in India, TB treatment was started with a DOTS regimen. That is 6 months of ATT, 2 months intensive treatment with isoniazid, rifampicin, pyrazinamide, ethambutol, and a 4 months maintenance therapy of isoniazid and rifampicin. So ethambutol is given just for 2 months. However, due to drug resistance, WHO changed their guidelines. This was incorporated in India in 2016. And with this revised regimen, there was a marked change in both dose and duration of ethambutol, which led to an increased cumulative dose of ethambutol. So these are the changes in the revised National TB program. Here, ethambutol is given in both intensive and continuation phase, and the duration is increased from 2 months to 6 months, and dosage also from thrice weekly to 6 months. So ethambutol is given a fixed dose. I will explain. It may exceed the safe dose of 15 milligram per kg. Here, one tablet contains all 4 drugs. That is INH, rifampicin, pyrazinamide, and ethambutol in this following milligram: 75, 150, 400, and 275. So that means you really cannot separate ethambutol alone. So in this revised program, again, in the intensive phase, all 4 drugs are given. And in the continuation phase, 3 drugs are given, only pyrazinamide is stopped. So you can make out that ethambutol is given in both intensive and continuation phase. But the good thing is that they're divided into weight category. So for example, if a patient is say 60 kg, he has to take 4 tablets of this, both intensive and continuation phase. But if this is what I've written in brackets, is the approximate dose. So that comes to like 22 to 20 milligram, which is actually higher than the 15 milligram per kg dose that is recommended. So that means in this revised program, there is a higher chance of toxicity. Now, taking cognizance of this, neuro-ophthalmologists and other specialists in July 2020, under the aegis of Indian Neuro-Ophthalmology Society, they gathered together to deliberate on prevention, diagnosis, management of ethambutol toxicity. They came up with a consensus statement, and that has come out as an article in IGO. So these are the important recommendations. First is that there should be an increase in the awareness of physicians, because physician is the first person coming into contact with the patient. They should ask for risk factors, and patients should be informed about the ocular toxicity, and they should report as soon as they find a decrease in vision. Patient should be referred for ophthalmic evaluation before starting treatment. Then the patient is aware that such a possibility can happen. High-risk patient should be followed up every 2 months. So the treating physician, he is the key person. He should ask for a decrease in vision at follow-up visits, and ideally just a visual acuity chart in his office, he can do a quick vision assessment, and ethambutol should be stopped at the first sign of ocular toxicity. And as I said earlier, basic investigations, visual acuity, visual field, OCT, VEP should be done. But the important thing is that patients should be taught to check vision at home. Even just giving him a simple Amsler grid would be helpful. Now, children are a separate category. Though the risk is less, it is challenging to diagnose toxicity, especially in preverbal children. So parents should monitor the child's vision. So the take-home message is that there should be an increase in the awareness among healthcare professionals at all levels. Patients should be informed of ocular toxicity. The patient should be referred for ophthalmic evaluation before starting treatment at 3 months and 6 months, whereas high-risk patients should be evaluated every 2 months. And early diagnosis using a sensitive indicator such as VEP is critical to prevent irreversible visual field loss. Ethambutol should be stopped at the first sign of ocular toxicity. If vision deteriorates, INH should also be stopped, and patients should be informed that the visual recovery may be gradual and may take up to 2 years, and supportive treatment in the form of vitamins. The key factors are awareness of ethambutol toxicity, early detection of ethambutol toxicity, and stoppage of ethambutol at the earliest sign of toxicity. Thank you.
Thank you, Dr. Anna.
Methyl, actually, many people are just giving neurobion. That is not sufficient. You have to give, you should give the correct dose, 1,500 microgram of methylcobalamin. You can also give no, tablet is there. Yeah, Mega Neuron or even Rena Plus. But you must check, they should, because any multivitamin will have so many vitamins. But yeah, pyridoxine 40 milligram earlier used to be given along with the ATT, but now it's not given. But you can give it as an addition. But the actual thing is methylcobalamin, and you can also give now Neurobion. Actually, there's Neurobion and Neurobion Forte. Actually, Neurobion has a higher content of thiamine and riboflavin, but it is not available. Everybody is giving Neurobion Forte. So maybe just giving something containing methylcobalamin, such as like Rena Plus, that is easily available, and also a Neurobion or Neurobion Forte. That is, but you have to tell the patient that it will be a long term. Many of them go into Ayurvedic treatment or homeopathy, but most of them recover to a certain extent by within 1 year.
Thank you, Dr. Anna. What is happening is usually this the pulmonologist send the patient before starting an ATT for ophthalmic evaluation, and we record the color vision, visual acuity, and sometimes even field, and we ask them to start the treatment. What is happening is once the patient develops a visual symptoms, the medicines they are getting is from these ASHA workers. And these ASHA workers are not aware that ethambutol can have this toxicity, and they are more worried about the tuberculosis. They ask them to continue the medicines without looking into the ophthalmic features. So better ask the patient whenever there is an ocular symptom, you immediately report and meet the physician whether to stop the medicine or change to another drug. Majority of the medicines they are getting is not from the pulmonologist directly. First they start the treatment and then they send the patient to this ASHA workers, and they are getting the medicines from the PHC. Usually we see patients who have started 2 months, after 2 months they get defective vision, and this ASHA workers told them to continue the treatment. And when we saw the patient, it was optic atrophy. So if you diagnose early, then some amount of the vision may be preserved. So better to ask the patient whenever there is a visual symptom. Don't continue the medicine, report to the pulmonologist, ask them to whether to change it into some other combination.
And they won't
No,
send
no,
also before
it is
starting,
not
they
the
won't send also.
pulmonologist, it is ASHA workers, because this medicine is free and they are getting from, because they are getting the medicines free from the PHC, from the ASHA workers, not directly from the physician or.
I think in the
Because they are more bothered about the TB status, not about the vision. So they ask them to continue the medicine. It is always better to finish that 6 months course. That is what these ASHA workers are telling. That is, if you stop in between, that can lead on to resistance. They are more bothered about the drug resistance and continuation of the TB treatment. Now the last talk is by Dr. Mahesh. He will be talking on common mistakes in HCQ screening.
Thank you, everyone. So this is a very important topic because every day I see a lot of references where the ophthalmologist has given a letter to rheumatologist. There is some scotoma in the field and OCT shows thinning. So stop the medicine. This is what all our members, our ophthalmologists are giving report. And this is actually wrong. I want to show some slides. What are the mistakes that we do when we screen for HCQ. The recommendations of HCQ screening has been modified based on the 2016 AO guidelines. And there are actually HCQ is a fantastic drug given and it's something like a drug of choice for SLE and lot of other diseases, steroid sparing drug. So that is the beauty of this drug. It finally affects, it causes changes in the retinal photoreceptors. Not, it primarily affects the retinal photoreceptors, mainly cones because of the central accumulation of cones. And once the cones degenerates, the other outer nuclear layer also degenerates, then RP goes. Once RP goes, there is no recovery. So this is the pathology, how HCQ affects this thing. So daily dose, this thing you should remember, daily dose greater than 400 milligram, 200 milligram BD, for around 5 years, or a cumulative dose of more than 1000 gram for more than around 5 years can theoretically cause accumulation of the drug. But this is modifiable because some patients have liver disease, renal disease, clearance will be different. So underlying retinal disease may be there. So these are all things that can affect. So, but usually it's a very safe drug. That is what I want. So all of us know what is the finding? Bullseye maculopathy. Bullseye maculopathy is the last stage of the disease. At that stage, there is no point in diagnosing. You can't do anything. It will not recover and finally it will further deteriorate. So that is not the importance. We have to find the thing at the early stage and then stop the drug as and when necessary. So what are the earliest findings in disruption in HCQ? The field shows some paracentral scotoma. This is 2005-7 like that. Autofluorescence is very useful. Some hyperautofluorescence is there. And here, correspondingly, there is a disruption of the EZ, ellipsoid line, which is the photoreceptor the layer, that EZ loss is there. And sometimes RP also will degenerate. So this is the typical finding. And corresponding to that area, there is a multifocal ERG, waves are reduced. So this everything should be correlatable. Then only you can say there is definite HCQ change. So statistical risk is very less, in fact. Different studies are there. Some studies show 7.5%. The risk of toxicity in less than 5 years is only 1%. Up to 10 years, it is 2% only. That means if a patient is taking HCQ for 10 years, the chance of getting a problem is only 2%. 98% will not get a problem. There are two things based on the ideal weight and actual real weight and ideal weight. Initially, they used to calculate dosage based on ideal weight. Now it is a real weight. That is a real weight that is calculated for giving the drug. That means a thin, frail person will get less dose actually. So baseline screening, a person is referred to you. You should have a baseline screening of fundus examination, visual fields, and OCT. This is a baseline test, even if the patient has comes at 6 months or 1 year. This can be used for further future tests. Then the annual screening actually begins after 5 years of use. Or if there are some risk factors like some other liver disease or something, obesity or something like that, you can call little earlier. Okay, so recommended screening tests are automated visual fields, usually 30-2, why I will tell you. Then SD-OCT, not time domain OCT. The 50% of OCT that I see in my practice is referred by some, where the doctor has done a time domain OCT and found a thinning and then stopped the drug. It is very dangerous to stop the drug unnecessarily. And multifocal ERG is only in some cases we do. Autofluorescence we have, so we do that. Microperimetry, all these things are not done routinely. Time domain OCT has absolutely no value in HCQ screening, I am again telling. And also color vision, all these things have no value. So once you detect it early, you can stop it so that it doesn't progress. But like in ethambutol, once it is beyond one level, you can't. So this is already that you can see that there is a something like a bullseye here. Vision is already gone. And this is multifocal, multicolor imaging. You can see that already there is something like a bullseye. And infrared and fundus autofluorescence, a typical bullseye is there. Wherever that dark area is there, there is complete loss of RP and ellipsoid. Photoreceptors and RP are gone. The hyper autofluorescence area has some cells remaining. So this is the how to correlate autofluorescence and fundus picture and OCT. Now this is bullseye maculopathy. You don't need a big head for diagnosing bullseye maculopathy, and there is no use of bullseye diagnosing at this stage. Now coming to some other cases. So here this is a case where vision is quite good, and here from this area to this area there is loss of ellipsoid line. So that is the significance. And in the central area it is still preserved. That is called flying saucer sign, foveal resistant, because fovea is still, that ellipsoid line is present. Ideally, this is what I do. Across the macula, scan level by level, section by section, and see whether there is any ellipsoid loss in any of these sections. So you can see actually that the ellipsoid loss is mainly in the at the arcade. It is little away from the area. So this is typically seen in Indian population, Asian population, unlike a Caucasian where you get everything near. So with one section of the OCT, never comment. You have to sit with the machine, go from here to here and take all sections and then see if there is any ellipsoid loss. So then only you say there is some problem. Okay, now in this case there was a big scotoma, like a ring scotoma sort of thing corresponding to that loss of RP. So this is the other eye. So these are the goal of screening is not to stop valuable drugs at first borderline abnormality. Don't ask the rheumatologist to stop the drug. You give your comment. Whether to stop it or not is decided by the rheumatologist. So recognize definitive signs of toxicity. So this is another case where referred for HCQ screening for 2 years, 6x6 N6. Okay, field was reasonably good. And one doctor from elsewhere has advised thinning of fovea and stop HCQ. The letter is given, one of our friends only. This should not be done. Where is the thinning? They saw this green that and it is red in the center. So it is like managing a field based on grayscale. Never do that. See this, there is thinning, then stop it. So it should not be done. In fact, I did across the macula, there is a scan there. I did all the layers. There is absolutely no change. So this was unnecessarily, the patient has stopped HCQ and had a remission of all problems. She was asking me whether I can continue that. So this is what is happening by our ophthalmologist screening across Kerala. So please make sure that you sit with the machine, go through all the sections, then only give a comment to stop the HCQ. So the mistakes are, 1, don't ask to stop HCQ based on central macular thickness. Now don't tell us there is thinning, you stop HCQ. That is absolutely rubbish. I am talking with little, because I see this daily. So don't ask to stop HCQ based on few scotoma in the paracentral, because unfortunately field is a good test, but it is difficult to, patient finds it very difficult to do. So with your OCT, you sit with the patient across the section, you just see, you will be able to find out. Check history. If it is only 6 months, patient is unlikely to have HCQ toxicity. So use a little common sense also. That is all. So in the reply letter, you write, no HCQ related changes in retina, suspicious changes in OCT, autofluorescence or field, need closer follow-up and repeat test. Definite HCQ changes like the first one may be stopped. Here you can definitely say. there is no point in stopping, but you can see. Then the fourth one is where there are other changes in retina like CSCR or AMD or drusen or something. So the early HCQ toxicity may not be picked up. Okay, this you can comment clearly. Because of the other diseases or CSR or AMD, HCQ toxicity cannot be picked up. Put the ball in rheumatologist court. Let them decide what they want. Okay, so these are the four reply that you have to give. HCQ is a very safe drug. Do not ask to stop the drug based on some vague findings. You are doing harm to the patient. Thank you very much.
Thank you, Dr. Mahesh, for that informative talk. Now we have come to the conclusion of our talks. So if anybody has any doubt, you can ask the speakers now. Excuse me, Dr. Mahesh. will-
30-degree field air.
If there is no definite change at all, you can write there is no HCQ related changes in the retina. Patient come for a follow up after 1 year. If actually, yeah, ഇത് HCQ മാത്രമല്ല. Yes, yes. So the second one is suspicious change. Here is something that sometimes OCT may show some changes. You are not sure. Better repeat the test after 6 months. You can call after 6 months. So there you don't mention to stop the drug. They can decide. Definite HCQ change, there is no problem. By the time vision will be bad.
Just one point to add to that, number 4.
Yeah.
Because just because there are some changes in the retina, we cannot say that we cannot follow up for HCQ.
Exactly.
If there are minimal changes, you can just say that we are going to take this as baseline and then
Exactly.
look for any
That's
progression.
right.
That
That
can
is the
be done.
importance of taking a baseline test initially itself.
And sometimes you can use the other eye. If there's one eye has changes, you can say that one eye has changes. We cannot use that. We will use the other eye for follow-up.
Absolutely.
That
Correct.
also you can, but it's your duty to inform the rheumatologist.
And please don't write stop HCQ.
മിനിമം ഡോസേജിൽ കൊടുക്കണം എന്ന് എഴുതാം. Can
Other, that is none of our decision. Because if it is low dose or high dose, that is their decision. That's what. Whether to give it or not, or whether to give in high dose or not, they may reduce the dose. Are you sure that if you reduce the dose, it will not progress? No. So let them decide. Why we are putting everything in our head? Our findings and our suggestions. Madam, correct. She is doing this interdepartment thing for a long time.
30-2 field in
30-2 ആണ് ചെയ്യുന്നത്. കാരണം ഇപ്പം ഞാൻ കാണിച്ച ആ വൺ ഫീൽഡ് ആക്ച്വലി all the changes are in the arcade. It's in the arcade. So our fellows are doing the OCT. So they will scan from arcade to arcade, white field, and anywhere they see some ellipsoid disruption, they will, and then we can correlate that with the field, whether correspondingly there is a field effect. And autofluorescence we have, everyone may not have. So these three are the best, I feel.
Sometimes you say the patient that so that you stop it and it is threatening their health also.
Yeah.
We have to set them in a proper way.
Actually, the one case where the doctor told them to stop, the patient has become crippled after stopping HCQ. So I was literally, patient was crying, can I start HCQ? That some, like that. I just want to put this message into our head. Where are our limits? What we should write? That is why.